Greetings from Chicago, Illinois, the 2015 annual meeting of the American Society of Clinical Oncology. This is Best of the Day. My name is Brad Monk. I'm a gynecologic oncologist from the University of Arizona, Phoenix. And this is my very good friend, Dr. Tom Herzog, Deputy Director and Associate Director of the University of Cincinnati Cancer Center. Tom, welcome.
It's great to be here, Brad. It's been an exciting meeting, and it's an honor to be here with you today.
It has been an exciting meeting, although I gotta say, I know you're a huge sports fan.
Yeah.
It's a little bit of a rebuilding year. We were not going to win a championship based on what we saw today at this meeting. I don't think there are going to be any new drug approvals that come out of data that was presented, but I think there's a lot of momentum that's building, ideally in the next year. But last year was good.
Yeah.
Last year we got 2 targeted agents approved in ovarian cancer, Bevacizumab in platinum-resistant disease, olaparib in 4th line and beyond in BRCA germline mutation carriers.
Right.
So let's begin to talk a little bit about Bevacizumab. Bevacizumab in a platinum-sensitive trial. Remember, the label is in platinum-resistant disease, but in patients that relapse greater than 6 months, tell us a little bit about GOG 213.
Well, it was a bifactorial phase 3 study that looked at 2 issues. One, the role of secondary cytoreduction, and it also looked at the role of adding bevacizumab to carboplatin paclitaxel backbone in platinum-sensitive patients. Large trial, and it was quite impressive in terms of showing an OS difference of about 5 months. Interesting statistical quirk, and I'd be interested to get your thoughts on it. Just missed statistical significance, but 5 months for us is certainly clinical. You know, in terms of clinical meaning, I think that's very significant. So I don't know what your interpretation of that study is. Different people call it different things. Some people say it's the most positive negative trial they've seen. So.
I think that's a good assessment. So when bevacizumab is added to carboplatin paclitaxel in platinum-sensitive relapse, the OS went from 37 to 42 months.
Yep.
P-value 0.056.
That's right.
Missed it by that much. But 5 months is 5 months.
Well, and you get into the 2-tailed, 1-tailed
right.
thing. There's some other things, nuances, if you will, that will go into the statistical analysis that with little change one way or the other, it becomes statistically significant. But it is what it is.
Right.
And that data, it needs to stand on its own. But we leave it to clinicians to judge what the value of that is. But it goes with our understanding of the role of bevacizumab in platinum-sensitive disease. And we need look no further than the Oceans trial, where we did have a primary endpoint that was positive with a hazard ratio of 0.48 by adding bevacizumab to carboplatin and gemcitabine.
Right.
In terms of progression-free survival. So.
But in the Oceans trial with CarboGem, there was no hint of an overall survival.
Right, right.
But there is here. So does the chemotherapy backbone matter in platinum-sensitive relapse? I mean, I get it matters with toxicity, but maybe there's an interaction with paclitaxel and bevacizumab. What do you think?
And it's certainly hypothesis generating. You take the data from 213, you combine that with the data that we have from the Aurelia trial, where clearly the paclitaxel backbone was the most effective in terms of absolute numbers for benefit in platinum-resistant disease. It makes you pause
right.
and wonder if it's not something about that interaction. Does weekly paclitaxel have something to do with it in terms of an interactive effect? As an other anti-angiogenic? Are they synergizing? What's going on there?
Well, I keep going. So in breast cancer, paclitaxel is the best companion.
Yeah.
Lung cancer, carboplatin paclitaxel. Cervical cancer, paclitaxel.
Right.
We're going to talk about endometrial cancer, paclitaxel. And maybe it's with cediranib, the only other OS trial in platinum-sensitive relapse, paclitaxel.
Right.
Here's the curious thing to me, is that the overall survival difference is bigger than the PFS. The overall survival difference in the ICON-6 cediranib was bigger than the PFS.
Yeah.
The overall survival difference in GOG 240 in cervical cancer, 4 months, was bigger than the almost 2.5-month PFS difference.
Yeah.
The difference in GOG 213, PFS 3 months, overall
also
survival 5 months.
Right.
It's changing the microenvironment. It's too many studies to be a coincidence, I think.
Yeah.
I don't know.
Yeah. It's hypothesis generating and certainly intriguing and needs to be built upon in terms of our future clinical trial design.
So and at this meeting we presented patient-reported outcomes. There was no difference in the patient-reported outcomes. In the maintenance phase of GOG 213, there might have been a little bit in the physical functioning, but really no difference in.
It was a deep dive. Into the quality of life, and as far as quality of life studies go, this was probably one of the best ones that's ever been done.
Good compliance.
Well, great compliance, which is usually a big drop off. Interestingly enough, higher in the Bev arm.
Right.
But.
Because patients have to keep coming back to give their Bev. They fill out their questionnaire.
That's right. That's right. But the important thing though is that. They looked at this from a traditional facto standpoint, using a large subscale of questions. They also looked at treatment-related side effects from chemo, as well as surgery. And then they did a dive into a physical function scale as well. So you had four different, really, data sets that they analyzed in terms of quality of life. You're right. There was some little noise with facto right before cycle 3. At 3 months and 6 months, there was a little decrement in the quality of life in terms of looking at the physical function scale. But for everything else, it recovered to baseline during the Bev maintenance phase, showing again that it was a drug that's well tolerated.
But I would have liked to have seen patients who are living longer feel better because they're maintaining tumor control. So I get it that there's no real significant decrement in the addition of Bev.
It goes back, though, to the real problem we have of measuring quality of life in ovarian cancer patients, which often, in the platinum-sensitive setting, is small volume disease with patients that don't have a lot of symptomatology. So how do you make an asymptomatic patient less symptomatic with treatment with a cytotoxic agent that can have side effects? It's a dilemma.
So that's where we were in November 2014. We got Bevacizumab approved in platinum-resistant disease. And then in December 2014, we got olaparib approved, olaparib being a PARP inhibitor. Tell us about the indication for olaparib here in the United States.
Sure. So somewhat unexpectedly, December 19th, I believe it was, 2014, the indication came in, and it's for treatment, not maintenance, treatment of patients in beyond 3 lines, so 4th line or beyond. So these patients have to have measurable disease, and they have to have a germline mutation in BRCA, either 1 or 2.
Okay.
And there's a companion diagnostic that's been approved by Myriad, et cetera.
So 2 take-home messages. One is that there's a companion diagnostic, but the second is this is a unique population where we've never really done drug discovery. We've always done platinum-resistant, platinum-sensitive. That was our conversation with Bevacizumab. But here, this is 4th line and beyond. So 3 prior regimens.
And who are these patients? Who are these patients?
I'm asking you.
I mean, you and I are struggling though to know who these patients are. I asked that question rhetorically though, because I don't know if we really know. What do we know? Well, from gleaning the data at this point, we know that these patients are platinum-resistant and platinum-sensitive.
Both.
That's right, and that's surprising. That's surprising. We also know that different histologies, we always think of high-grade serous. We know that patients respond to PARP inhibition with different histologies that also have these mutations as well. So we need to test, it goes into who do you need to test, which is an important question. And clearly you can't limit it to just high-grade serous.
Right. So there's also more BRCA 4th line, because the BRCA germline mutation means you're probably going to do better. So more of the BRCA negative patients have died, unfortunately, after 1 or 2, 3 regimens.
So BRCA is prognostic as well as predictive.
Interesting.
And because it's prognostic, to your point, you enrich the population over time with subsequent lines of therapy, because these patients tend to respond to any drug that causes DNA damage, of which many of our cytotoxic chemotherapy agents do.
And you alluded to the NCCN guidelines, which also ASCO has endorsed, that all epithelial ovarian cancers, not just high-grade serous, all.
That's right.
Okay. So that's fine. But you said maintenance therapy. So maintenance therapy.
So I mentioned maintenance, right? So we have other data that has looked at this in the platinum-sensitive setting with olaparib, and the European label is for maintenance. And
so the European label is different.
I don't want to confuse people, but again, the label here in the U.S. is for treatment, 4 lines and beyond, and for treatment, not maintenance. But in Europe, and I do think these labels will change as these subsequent studies come out. We have a frontline study, SOLO-1. We have a confirmatory study for maintenance in platinum-sensitive, SOLO-2 and SOLO-3. So those will come out.
I think one of the teaching points for our audience about maintenance is that patients who respond to platinum over and over again frequently have BRCA dysfunction, generally in mutations, but other BRCA dysfunction, and therefore good candidates for PARP. And so that's where this comes from.
Right.
But there's other homologous recombination repair related genes other than BRCA. At this meeting, there was an abstract on the Clovis drug, rucaparib. Tell us about what sort of biomarkers are available to identify other homologous recombination repair deficient patients, but are not BRCA germline mutations, so still might respond to PARP, but not related to BRCA. Tell us about that.
So the abstract you're alluding to was the report from Ariel 2. And Ariel 2's chief objective was to identify patients who would respond to a particular PARP inhibitor, in this case, rucaparib. And what was very interesting is that they of course, looked at BRCA mutations, but they looked at other genes that are associated with homologous repair deficiency. And so they were able to come up with a number of genes. The most prominent one was the RAD51C, expressed almost 27% of the time in their series. So really impressive. They also showed the important role of loss of heterozygosity in that study. Again, setting up the environment for bad DNA repair.
For a broader application of PARP inhibitors.
Beyond just BRCA mutations.
They call that genetic scarring.
That's right.
Interesting. All right, well, let's keep moving. It's a good biomarker discussion. The only validated biomarker is BRCA. In fact, let me ask you, because I'm curious, a lot of people get genetic counseling involved to do BRCA testing. Should we just do BRCA in our office, since we should test all our ovarian cancer patients, or do we need to get the genetic counselor involved?
Well, I think that, it's a very vexing question, because in an ideal world, you would have a genetic counselor in every one of these cases. Absolutely. Their knowledge, the depth and breadth of their knowledge can really be helpful in many instances. And different patients need different levels of service. As I'm sure you know, you still see patients frequently and understand the complexity of some patients' desire for a great deal of information, and other patients just nothing but the facts, sir. And in this case, I tend to triage a little bit based on my impression of how much information the patient wants. The problem with genetic counseling for us right now is availability.
Right.
There's a shortage of genetic counselors based on the demand.
Because the insurance may not pay for it.
And that's the second problem I was going to get to is that's a financial issue for sometimes it isn't covered. And so that's a big problem. So what does that mean in a practical sense? Well, for those patients who have a complex situation, or you get variants of undetermined significance, all those types of things, I think you really need to invoke the skills of a genetic counselor if you can.
Okay.
For somebody who just wants testing, then that's a different thing. There's the question is what do you do with the testing? When do you test, and how does it help your patients, right? So one of the things that certainly you need to think about is this sets patients up for clinical trials with PARP inhibitors.
Right.
The other thing is it informs their whole family.
Right.
And that can save lives.
Right, that's the cure for ovarian cancer.
That's absolutely correct.
Right.
And so that's a really important
risk-reducing surgery.
Absolutely.
Right.
So in a perfect world, again, please use a genetic counselor. It may not be practical or available for everyone.
So let's continue this biomarker discussion. I presented a trial of an anti-angiopoietin 1 and 2 molecule called trebantinib. It's distinct from anti-VEGF angiogenesis therapy because it's, again, a different target, a different cell type, a different molecule, and a different side effect profile. It causes edema rather than the anti-VEGF-associated toxicities. And I showed that ascites was a clinical biomarker for its activity, might even, in a pre-specified but not really an objective of a trial of 900 patients, predict survival of 2 months. Okay. But biomarkers are important. There are two other biomarkers that were mentioned. One was CD31, is that right? A biomarker for bevacizumab, a microvessel density?
Yeah, so Mike Beer's group at Harvard analyzed the results out of GOG 218, and they were really looking for predictors. I mean, the holy grail with bevacizumab has been who should get the drug, because clearly it has activity, but it has toxicity, and it clearly has significant cost. So if we could better define who should get this drug, we could certainly do a better job in terms of being able to make sure that we have the greatest clinical utility for our patients. So he did some biomarker work with that. It's hypothesis generating. It's very interesting. They also looked at VEGF levels, which has been looked at before, and that played out as positive as well.
But the lead hypothesis was CD31 microvessel density.
That's right.
Okay. And then our listeners are probably very familiar with pertuzumab. Pertuzumab being used in breast cancer.
Right.
You know, we want to use it in ovarian cancer, so they did a small 100-patient randomized trial in HER3 low. Right. Pertuzumab with chemotherapy, physician's choice versus chemotherapy. What did you think of that?
Well, you said it earlier. It's a rebuilding year. It wasn't. I had hoped for more from it. You know, what's interesting is the breast strategy actually came out of GYN literature.
I know.
When we looked at a phase 2 along with GEM. So it was very interesting in terms of identifying that low HER3 subgroup that seems to benefit from this particular compound. And indeed, it answered the bell in breast cancer. But it was sort of underwhelming so far.
So like we drafted him and then traded it.
Yeah, pretty much. Looks that way. And he's hitting home runs for another team, it looks like. Yeah, yeah.
So the study was positive, but 2.6 to 4.3 months PFS, that's not enough really to get
the
people
activity
excited.
looked modest.
Yeah, okay. So as you know, I chair the cervical cancer committee. There wasn't a single cervical cancer abstract presented, I'm sorry, at least in the oral session. So let's finish with endometrial.
Okay.
There were 2 endometrial trials. One was a cooperative group trial, which used to be the GOG, now it's Energy Oncology, 86P. Right. Tell us about that 3-arm study.
Well, it was a 3-arm trial that it's a little hard to interpret because they didn't really have a control. So it was a little difficult. It would have been nice if there was just a carbopaclitaxel arm. So one of the arms they had Bev, one of the arms they had temsirolimus, and the third arm was
ixabipoline.
So it was a unique approach. No big differences in PFS.
In any of them.
The response rates are similar, but an OS difference that was seen in the carbopaclitaxel bevacizumab arm.
Okay.
So. Somewhat interesting.
But didn't make a PFS difference.
That's right.
Well, that makes sense.
Right.
Small phase 2.
Small phase 2. So
but,
you're
but
worried.
the second study also was cleaner. Was carboplatin paclitaxel, Bev, which is really what you're talking about again in recurrent endometrial cancer.
Yeah.
That's probably cleaner.
Much cleaner.
So tell us about that.
So this was the MITO N2 trial, and they had a significant increase in PFS. Went from 8.7 to about 13 months. And more importantly, it correlated with the response rate going up as well. It went from 54% to 72%.
Hazard ratio 0.57?
Yeah. So pretty impressive.
So is this the new standard? Should we add bevacizumab to carboplatin paclitaxel based on the OS in the first study, which you were rolling your eyes about?
Right.
And now a 3 or 4 month PFS difference here?
It calls for a large phase 3.
Right.
It needs to be validated. These numbers are relatively small, but it does call for further investigation because we need something.
We do. We need a
targeted
therapy in endometrial cancer. You know, I was struck by the toxicity. Yeah. So endometrial cancer patients with recurrent disease, that is, which, you know, the young patient gets a hysterectomy and is cured generally. The older patient has a different biology, sometimes gets a recurrence, sometimes serous cancers. But they had a lot of toxicity, even from the chemotherapy.
That's right.
And I think that contributes to the difficulty of doing clinical trials in this space.
Absolutely. Absolutely. Yeah, it's a tough patient group, and we tend to autochronize from ovarian cancer patients who we give a lot of chemotherapy to, but they're a different patient population. They really are. a lot of diabetes, a lot of hypertension as baseline characteristics, and they tend to be quite sick.
Okay. So an exciting year last year, 2014, leading to the approval in November of Bevacizumab in platinum-resistant disease. The new study is GOG-213 in platinum-sensitive disease. 5 months of OS, but just missed statistical significance.
Right.
You did a very nice dialogue on olaparib and BRCA testing, trying to get better biomarkers, CD31, ascites maybe for anti-angiogenesis therapy,
right.
pertuzumab, not good enough, and then bevacizumab needs more study in endometrial cancer. Any final thoughts?
Well, we did have a couple of abstracts on PD-1,
Oh,
PD-L1 checkpoints.
Yeah, go ahead.
And I think those were really important as well. Getting back to the theme of, I guess, our talk, they form a foundation.
Right.
They weren't overwhelming. They weren't overwhelming in terms of the responses that you saw, but I would suspect that they're going to be part of a backbone along with other agents. Right. So used as single agents, not all that great. You were looking at anywhere between a 10% response rate approximately in one study, up to about 17%, all PRs, one CR.
70 is what you get in lung.
That's right.
Which is better than docetaxel.
That's right. So that was looking at 2 different PD-1 checkpoint inhibitors.
So and there's a third avelumab from Pfizer. So there's Pembro, Nivo, and avelumab.
And that was a 17%.
Yeah.
They had 4 out of 23 that responded in that PR.
We can't lose track of immunotherapy in
I
ovarian
think it'll
cancer
form
and
a
cervix.
backbone for some of our patients. So, you know, I think we're getting to where we're getting these snippets of data. We're getting glimpses of what the future is going to hold for these patients, in which we're going to have a backbone of maybe immuno-oncology for these patients, a backbone of anti-angiogenesis for these patients, in which maybe they get those types of drugs along with different chemotherapy agents in multiple lines.
Right. Sequencing is the key.
Sequencing, and then we have our PARP inhibitors and another backbone for our BRCA and other genes related to homologous repair deficiency. So there's 3 backbones that are emerging right there, and there'll probably be more in future meetings. So it's an exciting time.
Listen, I've been with Tom Herzog from University of Cincinnati. I'm Brad Monk. This has been Best of the Day. Thank you very much, and so long for now.